diversion work, like all the array of services there. So I'm very excited to be here.
Wonderful. Welcome.
I can go next.
Great.
I'm Zaire Cullens. I work at Duke University in the Bellwether Collaborative for Health Justice and am an incoming PhD student under Dr. Lauren Brinkley Rubenstein.
Welcome. Anybody else new? Let's see.
I'm new. My name's Matt Griffith. I'm a pulmonary and critical care physician at the University of Colorado, and with some of my colleagues, we made a website called Scopes and Shields to kind of advise physicians who are in the inpatient world on kind of how to maintain, deliver patient-centered care for people who are justice involved when they come into the hospital and are interacting with providers that aren't used to that. And we're presenting at ACCJH this year. It'll be my first time going.
Wonderful. Then Hannah, I think, is new.
Yeah, hi. My name is Hannah. I'm a PhD candidate at the University of Minnesota and broadly study mass incarceration and deaths in prison. And so I'm really happy to be here. I come to this work through work in prison education. So thanks to you all.
Fantastic. And Jim, I don't think you've been to these meetings yet.
No, thank you. Jim Verhoy, program manager with Amend, University of Minnesota alumni. Got my PhD there and taught in 5 of Minnesota's prisons. So I'm sure we know some of the same people, Hannah, although that was kind of a while ago. But great to be here. Thank you.
Wonderful. Well, welcome everybody. I think that a couple more people may be joining, but we're thrilled to have all of you here. And briefly, I think Nick and I were going to just give a couple of very quick updates. We will introduce our speakers. We have 2 extraordinary speakers today who will give a presentation on the incredible work that they're doing. And then we'll open it up for question and answer. So again, wonderful to have you all here. As you all know, this is the kind of reaching the end of our hopefully initial 5-year grant funding from the NIH for the Arch Network. We've had, I think, 5 extraordinary years, 4.5 extraordinary years, and all because of all the work that you all have done. We got our initial reviews back from the NIA for our renewal, and actually they were very positive. We got a fundable score. It's kind of on the bubble, but hopefully possibly fundable. So we're just getting the summary scores actually came in this morning, or the summary comments came in this morning. So we're in the process of looking at those, and we'll respond to them in the next week, and we'll let you all know. It's definitely possible. It's not a sure thing, but it's definitely possible that we'll get funded again for another 5 years. So that is very exciting for us, and you will all be the first to know when we find out. Another announcement is, as a reminder, we will be having our first in-person meeting at ACCJH, and that is on, Shoka, can you remind us when and where that is?
It's going to be on April 10th from 6 to 7:15, and the room is the Chula Vista room where the conference is being held.
So if for all of you who are going to ACCJH, if you are not on the email invitation list for that, please reach out to me or Shoka or Nick, and we'll make sure that you have all those details. But we're really excited for the possibility of getting together in person. And thanks, Lauren Brinkley Rubenstein, for making that a possibility for all of us.
Bree, I was saying,
yeah.
Shoka, do you mind putting your email in the chat just for
Sure. Yeah.
Because you'd probably be the best person for people to reach out to, and then they can get added to our list.
Definitely.
Hedging the bets, like we are definitely, possibly, maybe gonna get refunded. No, what fingers are crossed. I am hopeful, and as those who know me, I'm not the optimist, but I'm going to be optimistic here.
Yeah, it was a good score. Okay, so without further ado, I will introduce our incredible speakers today. Both come from the Humane Prison Hospice Project, which is a California-based nonprofit. I'm going to let them talk about that, so I'm not going to give background on that, if that's okay, Lisa and Fernando. But what I will say is these are, as you all know, and those of you who are new to us, which we'll know now, is that these bi-monthly meetings are really a chance for us to explore research methods, explore projects and programs that are research programs that are in the works, but also to hear from community-based organizations who are doing incredible work in areas that dovetail with the research that we're doing and potentially even to imagine collaborations. And so that is that is what this session is about today. We're going to hear about Humane Prison Hospice Project. Lisa Deal is a registered nurse and a public health advocate who has a passion for being with the dying. She actually was a community health nurse caring for patients with AIDS in Boston during the 1980s when she got really interested in this work. She has a master's in nursing, a doctorate in public health. She spent several years working as a clinician, a research associate, a policy analyst, and an editor, grants officer, hospice executive. So she's very well versed in this area, and then was asked to take over the role of executive director for the Humane Prison Hospice Project. As executive director, she works on everything from strategic planning, fundraising, program management, and also bringing together her incredible team to ensure that people dying in prison receive compassionate end-of-life care. Fernando Murillo is well known to my program, and I had the incredible fortune of having Fernando work for me for several years, many years, I guess, which was incredible. And then he found his dream job with Lisa. So Fernando is now program manager at the Humane Prison Hospice Project. He's justice involved. He was incarcerated for approximately 24 years. While he was incarcerated, he worked in the only licensed hospice in the California prison system for about 5 years. He has received extensive training in end-of-life palliative care from University of Southern California and UC Davis. And at the Prison Hospice Project, he really focuses on developing and implementing training for incarcerated residents to provide end-of-life palliative care in the carceral setting. And I'm going to let him talk more about what he does and what their team does together now. We're going to hear from them for about, shall we say, until about 1/4 of, and then we can open it up for question and answer. Does that work for the two of you?
That sounds great.
I'll let you know if you're getting close to that time so that we can make sure that there's time for discussion.
That sounds great. Thanks so
Wonderful.
much, Bree. And before I go any further, I just want to say thank you so much to Jamila and Shoka for making sure that this is all running so smooth and wonderful. So thank you guys. Shoka, is it okay if I screen share?
Of course.
Okay, so much. Thank you so much. I'm going to be sharing some slides with everybody. Can you guys see my screen?
Yep.
Okay, welcome. So my name is Fernando Murillo, as Bree mentioned. For everybody that's here today, thank you so much for being here. I'm a program manager with the Humane Prison Hospice Project. And right now I'm going to be introducing my director, Lisa Deal. Lisa, if you don't mind, you can let me know when you want me to change slides, but without further ado, go ahead, Lisa.
Thank you. Thank you all for having us. This is what a fabulous group. And I hope that you'll learn some from our presentation today, but I have a feeling you could all teach us, at least me, an awful lot as well. So Fernando, do you want to go to the history slide? So I'm going to talk a little bit about Humane's history, and then we will kind of delve in more to what we're doing, boots on the ground now. So Humane is, as Bree said, a small California nonprofit that's really devoted to helping transform the way incarcerated people die through education, advocacy, and our biggest area of work is around training incarcerated peers how to be end-of-life caregivers and grief companions. The organization started in 2017 and was founded by a fierce advocate who asked an attorney, Mike Satras at San Francisco, how people die in San Quentin, and he said horribly. And her name was Sandy Fish, or is, and Sandy was determined to make a difference in this area. So she pulled together a team of a palliative care social worker and nurse, Lady Bird Morgan, and a formerly incarcerated man by the name of Marvin Much. And they launched Humane really with the goal of bringing end-of-life training and care into San Quentin. We then had the opportunity to go into San Quentin to take over and lead a group of peer supporters who had really come together around crisis intervention and suicide prevention. They were called the Brothers Keepers, called the Light Keepers today. But they were really asking for this training on how to support their peers who were aging, dying, seriously ill, and how to support their peers who were grieving losses in their own lives out in the free community among family who they couldn't train or couldn't be with. So Humane led the Brothers Keepers program for 2 years. We had 2 cohorts of men that we trained. I think there were about 24 total. And the second cohort was going to graduate right when the pandemic hit. And then, as you all know, that really shut things down for the next couple of years. During that time, we continued to support the Brothers Keepers at San Quentin through letters and such. And we also began partnering with Dr. Michelle D. Thomas, who I know many of you know, who's been the medical director at the only prison hospice in the state of California, at California Medical Facility for several years. And Dr. D. Thomas was recently, at that time, moved into a role of chief executive of palliative care for the State Department of Corrections. And so she came to us and asked us if we would partner in creating a really comprehensive curriculum around training peer caregivers in palliative care and end-of-life care that could then be scaled to the state, throughout the state prison system and beyond. Because there's been a prison hospice for a few decades now at California Medical Facility that's been wonderful, but a lot of the processes haven't been pulled together in a way that they could be replicated elsewhere. So we worked very hard. Fernando was involved at the time. Bree was giving some of Fernando's time to us. He was with Amend, and Dr. D. Thomas and her team and our team at Humane, and created a wonderful manual that we're using today. We have piloted our program in 2 prisons so far in California Medical Facility and Central California Women's Facility, which Fernando can speak to more later. We're looking to go into 2 more prisons this spring, hopefully another in the summer, another in the fall. So the plan is to try to do this training at as many prisons so that there's this network of peer caregivers to really address the end-of-life needs. So yes, here it says, what we do, we educate the public and key stakeholders about the needs of people who are aging in our prison system. We provide peer caregiver training. And more recently, and Fernando will talk about this, we try to support compassionate release efforts through developing community partnerships to increase housing and care for those folks. Fernando, do you want to go? I'm not going to talk a lot about statistics today because I know that this is a really educated group in this field, but I just want to say a few things that, I think will help us kind of ground what we're doing. So as we all know, the prison population is aging. And by 2030, it's estimated that 1/3 of incarcerated people will be elderly. Prison accelerates aging dramatically. So elderly is considered somewhere around 55 years. And very importantly, prisons were not designed for older people, either the environment, the physical environment, the milieu. They're asked to do things, oftentimes climb up in bunks, stand for call, be able to hear. And it's really a problem. So this is really a growing national issue that we're hoping to make a small dent in. Yeah, with that, Fernando, why don't you jump in and start talking about the programming that we're doing?
Yeah, sure. Thank you so much, Lisa. So as Lisa mentioned, we have trained approximately 2 cohorts. The first one was at California Medical Facility. We trained approximately 12 participants. And then at California Central Women's Facility, where we train approximately 27 participants. We have a robust training manual with 15 modules that cover everything from transferring spiritual guidance. We have a module that discusses in depth the benefits of having a multidisciplinary team. And we focus on a lot of essentials around like pain management, trauma-informed care, And we also discuss, and I share all of my personal experiences around like the importance of peer support in this setting, and all the benefits that it has into like improving environment of normalization. So we could talk a little bit more about that later, and Amanda is so familiar with that. So the importance of the peer care model is the peer care model is really important because it promotes a multidisciplinary team. And a multidisciplinary team consists of the correctional staff member, primarily the correctional officer, the correctional healthcare member, and the incarcerated person. When the focus is around providing end-of-life care to a patient, everybody is on board to providing compassionate end-of-life care to the patient. And the benefits of having incarcerated people being a part of a multidisciplinary team definitely relieves the stress of the people that are working in that setting, primarily the correctional healthcare staff members, correctional healthcare members, and it provides incarcerated people skill sets that will help them reenter the community where they can have an actual a job and monetary skills that will help them reintegrate successfully back into society. Yes, so accomplishments and future plans. So far, we were able to train 39 people approximately. Our training was well received. We have some questionnaires that we present to our participants on the back end of our training. And so far across the board, people have been very satisfied with the training we have provided. Some of the feedback that we received was like, this is one of the most profound trainings and programming that we've offered, that has been offered to a lot of the incarcerated people that we have trained. For this year, we plan to train in approximately 3 to 4 more California prisons. And we intend to model the scale for other institutions in different states throughout the country. We have a lot of interest right now in the state of Michigan and the state of Washington. So we plan to do some modeling to scale here shortly in different states. Compassionate release. For people that don't know about the compassionate release process that happens in California, before there used to be like this gigantic barrier that was erected in which the patient used to have to go through the BPH process, which is the Board of Prison Hearings, and that would be reviewed and ultimately be kicked over to the Secretary of Corrections to review, and then go to the county of origin, and a lot of patients would die in the process. With a lot of efforts from Dr. Michelle de Thomas and CDCR, there's less barriers now for a patient to have their case reviewed. And I believe that the case goes directly to county of origin after the recommendation for the PCP. But one of the biggest barriers that the patient has after that process is a place to go. And in the community, not many nursing facilities and hospices are willing to receive a justice-involved patient. So what Lisa and I and the UMaine team have been doing is doing community outreach and talking to transitional homes, nursing homes, and hospice houses to see if we could develop partnerships to one in the transitional home area to designate one bed where we can have it set aside, train the justice-involved people that are in the housing, in the transitional housing unit, as well as staff members, to be like caregivers, similar to what was mirrored in California Medical Facility. We've been reaching out to CalAIM to see where we can address some of the gap funding that is present. So some of these beds could be set aside and paid for, as well as the medical treatment and hospice care that they will need in the transitional home. And I have been doing a lot of inquiries by phone as well as in person to get people to understand the need of welcoming justice-involved people into their skilled nursing facility or hospice house. So that is something that we're currently working on, and something that we want to really address, because there's so many people that qualify for compassionate release ultimately get granted and still die in the prison system because there's nowhere for them to go. So challenges and solutions. So one of the biggest challenges, of course, is stigma. And this is related to the compassionate release process in the community. Now, people are educated or well educated about the realities of what happens to justice-involved people and why there's such a need for there to be like community-based partnerships for destinations for compassionate release patients to be able to go to. The other thing is, as Amin is all too aware of, is the resistance to change within the carceral system, where correctional officials start learning that incarcerated people will become a part of a multidisciplinary team. We hear, we have heard, so many times, not only with the men, but with Humane Prison Hospice Project, that we don't want to work with incarcerated people. We don't think that it's a good idea for them to be working with patients. But ultimately, when they see the process happening and it's implemented into their system, they see the benefits of having an incarcerated person working side by side with them, with the focus of providing compassionate care to a patient. So some of the strategies that Humane has been using effectively is sharing a lot of information about what we do, sharing information of like some of the surveys on the back end that we've taken from some of our participants about the benefit of having peer caregivers in their institution. And we are committed to ongoing evaluating and adapting to emerging needs throughout not only the state that we're currently working in, but a lot of the programs we anticipate, systems we anticipate working in the future. So with that said, I think that's the end of our presentation. Please, by all means. So if there's any questions, discussion, we definitely will open up the floor. Any questions you may have, so we can provide some follow-up. And Bree, by all means,
I'm just going to start by saying, oh, sorry, go ahead, Lisa.
No, I was just going to say one more thing about compassionate release, and often I lead with this, is that we really, we see compassionate release as the gold standard. It would be ideally if what we do wasn't needed because everyone was getting out and they had either a loving family or a safe and loving place to go to in the community to die as a free person. But unfortunately, for many reasons, that's just not a reality. So we're trying to do make sure they have really good care while they're in prison, at the same time working toward this broader goal of places for people to be cared for in the community so that they can get out.
Incredible. So first of all, so thrilled to hear about the work that you all are doing, and it's really inspiring. I bet that there are so many different directions that this conversation can go, and I'm really excited that we have a lot of time to talk about it. People might want to ask anything from like, what does the content look like? How long is the training? What do people get trained to do? But also one thing I have a number of questions, but I'm just going to take the facilitator's prerogative and ask the first one, which is really, I think it would be very interesting to hear from you all, what would be helpful in a research agenda from researchers on this call? You're going to be doing the evaluation of your program. But what do you find that you wish you had in your back pocket to show to departments of corrections? Anything from, we throw around that 30% of incarcerated people will be, elderly by 2030. That was actually based on a Phoenix Sun-Times newspaper article that was like completely unsubstantiated. It may be true. It may be an underestimation. It may be an overestimation. But there are so many things that have become lore that I think researchers, on this call and throughout this network really should be starting to think about everything from demographics through to policy-related questions, through to healthcare-related questions, ethics around incarcerated people, taking care of incarcerated people. Is there anything that we can be helpful about that's either analysis or research that if you had out there, you feel like it would give you more kind of ammunition, if you will, to sort of make the point of how important your programming is? So I'll start with that question, and I'll open it up to others.
Yeah, thanks, Bree. So one thing that comes to mind, and you hit on a lot of really important points, there's actually not that much known about these programs. It is really hard to get data that isn't from 10 years ago on how many hospice programs there are in prisons throughout the country. The best estimate we use is of about 1,500 prisons. There's about, fewer than 100, I always say, but that data is years old. How many of those actually use this peer caregiver model, which we feel is essential for many reasons. These people are, learn skills that are useful in the job force if they get out. They're learning how to show compassionate empathy, maybe in ways that they weren't taught through their years of growing up. So there's a lot of good reasons. On the patient side, patients tend to trust. They can be very suspicious of the medical care providers in prisons, and they trust their peers. They open up to their peers. So it's kind of transformational on both sides, but there isn't a lot of data out there on that. And then, as Bree mentioned, just the numbers around how big a problem is this? How many people are there that are elderly? What diseases do they have? Kind of all of that framework so that training can be targeted more. We cover, dementia care training, but what are some of the other issues that are going on? So those are things that come to mind to me immediately. And I'm sure I could think of like 10 more because there's so many areas of research needs. Fernando, do you have anything else that comes to mind in terms of research that would be helpful in this area?
Yes, the benefits of like the outcomes, the health outcomes of everybody involved. As we know, like the debilitating health effects that happens in these spaces are just horrible. And as Bree has noted so many times in presentations about the mortality rate of not only correctional staff members, but the terrible outcome for the incarcerated people that are living in these spaces. The projected health outcome for everybody involved is awful. I would like to see like a study of or potential research study of potential different outcomes of not only staff members, but incarcerated people that are working in these spaces after the fact. I think that in itself could be something that is researched, and if some quantitative data is accumulated to demonstrate that this is a benefit to this a benefit to this space, I think it will go a long way in the future to present that data to get Department of Corrections a little bit more on board with more of these partnerships happening, or community partnerships, and to implement programming like this, like in a broader scale. So I hope that's something that we can look into. So
I just love this idea of thinking about, in particular, the health and the healthcare needs of the incarcerated workforce. And I think we're seeing a lot more attention to that population in the popular press. And there's been like an extraordinary dearth of research about that occupational workforce in the academic literature. So I just love that idea, Fernando. It's a great one. All right, I'm going to turn it over to other questions.
I just want to point out, Nicole had a question, and maybe Fernando, you touched on this a little bit about how Michigan and Washington, you were trying to talk to folks there and getting into new prisons. So for those folks on the call, how have you all been able to engage correctional staff in trying to get buy-in for what you're doing, and suggestions maybe for others who want to start engaging their prison systems around some of this work?
Do you want to take that, or do you want me to start, Fernando?
I can start really quick. So I would like to share really quickly that there was a gentleman that I met in the Grantmakers and Agings Conference in Austin, Texas. And he is a philanthropist that works in the state of Michigan. And he shared a story about when he was doing some rounds in the Michigan Department of Corrections, that there was a need to address end-of-life palliative care in their system. And so he was so enthusiastic about meeting us that we, after the conference, we sat and we discussed the potential of working together. And we have been meeting with the medical providers in their system, and we are currently in the process of modeling to scale. So essentially, in that aspect, the networking component. The second thing is in California, we work very closely with Dr. Michelle DeThomas at CHCF, which is at headquarters, and she's the one that has been tasked to bring more end-of-life palliative care services to different institutions in the state of California. So she has been our primary advocate in making sure that we have accessibility to different institutions in the state based on needs assessments that her and Dr. Pfizer Rating are doing. And then so she'll contact us ask us to prepare, and with flexibility on our team, respect to our staff and our team, we work with the institution and determine whether we can roll out our training for a 2-week process in which we could come in for 2 hours a day, or if it's a model which we're going to be rolling out an 8-hour day training for 2 weeks straight. So we're flexible on that aspect, and we're mindful of institutional needs and institutional standards and safety and security of the institution. So when it comes to California, like I mentioned, we have Dr. Michelle Thomas, who is our primary point of contact, and we have been networking through conferences, to work in other states. So that's kind of like what we've been doing so far. So at least,
yeah, I want to add this a little bit. So we have some money from the Rita and Alex Hillman Foundation to really develop this model to scale. And, my hope had been that we would be able to have this nicely packaged set of work that we could just take to other states. And as we're talking with other states, we're learning that it has to be a lot more nuanced, and we have to really fit into the culture of the prison system in states where we go and really meet their needs where they're at. We're quite far along having discussions in Washington. Part of that, we had this entree because of the great work, quite frankly, Amend has been doing there for a number of years, and Bree mentoring, I think, a doctor named Aaliyah Moore, who was just hired to really expand and look at palliative care and hospice care in Washington State. So we're kind of getting in on the ground floor with those programs being developed in a more comprehensive way. We're also talking with some folks at the Department of Corrections in Oregon, connected through a physician in a community-based hospice who was asked to do some work in the prison. So every state is looking at it a little different. And so we're kind of grappling with this now. And I would love if anyone on the call has, have a follow-up conversation on scaling programs and the best way to do that, because it feels it has to be very nuanced. And like Fernando said, we try to be as flexible as we can. Our training, the model that Dr. D. Thomas wants us to do in California is it's basically 80 hours of training. It's 15 modules. And it takes, I hope the math adds up, but kind of, we can do like one module in half a day, and then we have some catch up time. But it's 2 very intensive weeks, which is really a lot. It's a lot for the facilitators, it's a lot for the folks, but it really also, we found Central California Women's Facility that it built a real sense of community and was really, really life-changing for a lot of those folks. We go in teams of kind of 4 people. We try to 2 facilitators, and then at least 1 kind of observer who can also pull an incarcerated person aside and give them some special attention. A lot of our teaching brings up a lot of past trauma. We do a whole section on trauma-informed care, and people are having to grapple with the experience of death in their own life. Often it was taking someone's life, so there's a lot of trauma around that. So we go in with a team. I have to say, our team does training, the 4 of us, but we also have an amazing group of volunteer facilitators who go in on a volunteer basis. They're trained by us to administer our curriculum, and they volunteer based on subjects that they have our content experts in. So it's a big process.
Stephanie?
I think Lisa just sort of spoke to my comment. So I love this so much that I am giddy. I have 1,000 questions, and so I will just follow up via email. But one of the things I was interested to know about was kind of that bereavement support. So in our peer caregiver work, that just keeps coming up, which is, it's great that we get the training, because there's a few different training module strategies that are being deployed kind of throughout the country. But even working with folks who are doing this work in the UK, we hear from our peer caregivers, it's great that we know about advanced directives and transfers and things like that. But then folks leave, and we don't have that continuity or support in terms of the grief and bereavement. like at Angola, right? We're burying people on a weekly basis. And so how do they come to terms with caregiver burden in the space, with that kind of that carceral care rub? So I was interested to know like how you all
Yeah.
This is a great question. I have an answer for you. So like we build into like a request from the institution that we are going to have follow-ups with our cohort. So we have our staff, we have spoken with each other before we roll out any sort of programming, and we determine that we intend to come back every 90 days for support.
That's awesome.
And this is around grief support as well as community support for the peer caregivers in this environment. We're actively going to come back to California Medical Facility on April 15th for one of our next follow-ups. So, and we coordinate this very closely with Chaplain Keith Knopf, who is the Director of Pastoral Care Services at California Medical Facility. And we're also going to be doing the same thing at California Correctional Facility for Women. And we coordinate that with their PIO as well as the staff that's working to coordinate the program or support the program. So
awesome. This is such an interesting, I'm just going to jump in here for a second because I think this is such an interesting question is you were asking Lisa about scale, and as you're thinking about scale, the question is, do you become the organization though that is going back, like right now you have 2 prisons, but if you have 40 prisons, which we hope you do, or 100, are you going back every 90 days to all those, or is a second piece of what you're developing the training and the tools for either, I don't know, some sort of staff-led or resident-led or right? Like to continue that work themselves. And that's almost a second training is the grief and the caregiver burden piece.
Exactly. Yeah. And we are kind of right now we're small and all of us want to go back and do it. So we're doing it. But our intent long-term is to either have volunteers or have benefit of community volunteers going in and doing this. Because the people who are incarcerated, just for them to know that people in the community really care about them. So we're trying to build, cohorts in the different locations where we go of folks who can go back in to offer that grief support. And as we scale to other states, we're really not envisioning that the Humane team, goes somewhere and plans for 2 weeks and does the training. We're seeing this more as we want to build local capacity and leverage local talent so that there's commitment at the local level so that we can go in and train, whether it be in Washington, it looks like we're going to be training some prison staff. In other states, maybe folks from the community, from community-based hospices, other sort of experts in the area to kind of own that and be able to carry that forward. Trained in our mode and our model and our curriculum so that it's done with the integrity that we intend it to be taught, because anyone can teach content, but this is much more than teaching content, and that we could provide virtual support for the facilitators going in. So this model of kind of going out in different places, I think is, and I'm saying all this, and please know that we're kind of creating this as we go and trying different things, but that's kind of where we're looking now. Fernando, did you want to add something?
Yeah, I just wanted to support that, what you just said. Like our team is like, we're doing logistical like analysis before we go to any state, beforehand. And what I mean by that is like, we're reaching out to local hospices, we're reaching out to local organizations around the institution so we could develop partnerships with them so they can support, as Lisa just mentioned, this programming once we leave. So, and yes, so that's what I wanted to support you with, Lisa. So. Christian?
Yeah, sure. First of all, I wanted to tell you a job well done on both of your work. This is absolutely incredible. And likewise, I have a million questions. But one question that I'm itching to ask is, if you could humor me for a little bit, say that you guys do grow and you're able to do more work inside of other prisons. do you think that this work would be beneficial in proposing to not only stakeholders, but policymakers as well to provide a humane aspect to people who are justice impacted and people who have been in prison before? Because there's a lot of talk, at least in the state of California, I know just recently they're discussing more expungement for people's records for people who haven't committed a crime in the next 4 years. And there's even a bill going around concerning if people who were convicted of a felony, they'll be able to communicate with another person who's convicted of a felony if they are a part of their immediate family, which is an absolute relief for a lot of people because when you're released, you don't have many places to go. So I'm just very interested to know has there been any discussions inside of your team to say, hey, we should probably bring this work and these reports to policymakers to influence that those bills and those policies do get pushed out, since there is a lot of talk when it comes to going in the right direction of prison reform and making sure that these individuals live healthy and happy lives.
You want to take that, Fernando? I think you should go for that one.
This is a great question, Christian, because this is something that our team was just recently discussing. We discussed this at length, and I can tell you this is a great idea, but at the same time, we are not in the business right now of discussing policy with lawmakers. We just don't feel like we are in the appropriate place right now to have these discussions, but we definitely would like to show policymakers what we're currently doing in the carceral system so they can get an educational visualization of what's actually happening, not only with our work, but the effects that it has on the environment and how it promotes something like here in California or something around the California model and how that promotes rehabilitation, normalization. So yes, but in the future, this may be something that we can discuss on a level that's a lot more appropriate. What I mean by that right now is we are not in the business of policy advocacy at this moment in time. And we feel like there's a lot of organizations that are doing this really effectively. But what we could do is partner with a lot of these organizations that are doing this outreach so we can share a lot of this information that could be beneficial to policymakers being a little bit more educated about the benefits of having these programs in their institutions. But as of right now, we're not prepared to do that. We feel like it's inappropriate for us to share those ideas with policymakers, but you are on a great track in respect to thinking along those lines, because those steps will come as time goes on for our organization. But as of right now, no. But Lisa, if you would like to follow up with something I said, please tell me.
Yeah, I would just say yes, that work needs to be done, and there are important stories to be told. And like Fernando said, we aren't doing that now. Partly is our funding and our capacity. If I had tons of money, that could be a whole other area of work. But we're also kind of trying to figure out how, because our success depends on positive relationships with departments of correction. They are our entry into these prisons, and oftentimes some of the advocacy work is not in line with where the departments of correction are wanting to go. So I think what we're doing now is more going to states where we are invited, because there is a desire for change. There is a desire to do better. So it's an easier sell, and we don't feel like we have to push back policy wise so much. Now there's a lot of states that this would not be welcome. And I think for the foreseeable future, we'll stay busy among those states that are welcoming. But so I think, to Fernando's point, we'll reassess that as we go. But that fine line between working with but not being of the Department of Corrections and doing things that could be perceived as working against them is a really fine one that we have to walk.
Other questions?
I just have a question about non-custodial staff. Having worked in education for many years, I know oftentimes there are teachers, for example, who spend 20, 25, 30 years of their career in the same prison. So they get to know people who live there. And as those people age, you know, they see that. I'm just wondering if you have had discussions or engaged at all beyond healthcare staff as part of people who contribute to the effort within facilities.
You mean like the correctional officers?
Right. So not the officers and not the healthcare, but anybody else.
Yes, I could respond to that, Jim. That's a very good question. So the second time that we administer this training at California Correctional Women's Facility, staff members would come up to me personally and thank me because a lot of the students, as a teacher, for example, a few of the students that this teacher had were women that ended up becoming terminally ill, very sick, and were in need of like peer caregiving and the type of end-of-life care that we were training on. And they were thanking us so much because they had personal and not private relationships with a lot of these incarcerated folks. And they understood like the humane treatment that they were going to be receiving in the SNF and the 505 and different places that women would be housed in. And they felt like this was something worth investing in. A program like this was worth investing in because they seen the humanity in the people that would be in their classrooms or in spaces like, you know, the Prison Industry Authority, where they would interact with each other as people, you know, over time. And so, yes, we've received responses from people in what I refer to as the prison community, the carceral community, and they have expressed, you know, gratitude and like making sure that this program was available. And they also requested if they can learn more about our program and even receive training on our program, so they can learn little bit more on how to best be present for the community that's aging and dying as well. So I hope that answered your question. That was spot on. So
yeah, it did. I know where I was, there were several tutors, incarcerated folks who had been tutors for many years in our adult basic ed GED program, and they would get to know people, but they would get old themselves as well. And the teachers would very often, you know, get to know them quite well. So yeah, I just thinking about staff outside of those in uniform and those outside of healthcare, I think.
Right. And I would like to share something really quick, Jim, and in my personal experience of being incarcerated. Like people, as you mentioned, the longer they work in corrections, the more they get in touch with their own mortality and the more the concern that they show to their community, even when culturally they're being told from a lot of their peers, like it's inappropriate, it's not okay to be close to incarcerated people. But the humanity that is present there and asking these questions are very evident. And I believe Michelle de Thomas has her hand up. So.
Hi, everybody. I missed the beginning. Unfortunately, I had another meeting, but I did want to say that we've worked really closely with our chaplains and done a lot of, we've even done a statewide training with the palliative care role of chaplains, and many chaplains who work in the prison setting are very excited to get engaged in this sort of work because they get kind of caught up in some of the institutional formalities that are associated with their jobs. And this really gives them an opportunity to practice like from their heart what they went into this work for. So that's one resource. We've also opened a memory care unit, and we've engaged our coach in the gym. And so he's got some of his the workers that do recreation in the gym kind of coming up and just working at the memory care patients, doing like chair exercises or even just playing games and bringing other sorts of recreational activities. So those are two examples I can think of engaging people outside of custody and medical.
You know, these are just, as you all are speaking, I'm just thinking about the research opportunities, which really are there are just so many. I mean, just this conversation alone, really understanding, speaking with all of the chaplains who are getting engaged in this work and understanding the ways that the vision that they see, the different ideas that they have for how to expand their role in this area and the importance of this role in the prison setting, and then also their questions and their needs and their training recommendations would be super interesting, not necessarily in California where it's pretty well you have a kind of a really nicely kind of oiled machine here, but in many other states where that's not happening, or this is just on the ground floor, that would be incredibly interesting project. I think also something that you talked about, Fernando, about this question of release, and we've talked so much about, we have one funded project through the Arch Network around sort of the Secret Shopper project of, you know, trying to understand, coming out of Rhode Island, of what are nursing homes and inpatient hospice facilities willing to take in terms of patients from incarcerated settings or incarceration settings. But I also think this idea of a set-aside bed in transitional homes is, I mean, that is brilliant. I've never heard that. And I know that we've been also talking, I think, Michelle, you've been talking, Lisa's been talking, many people have been thinking about this idea of the MCRP in California, but, you know, these transitional care homes that are like the end of your sentence in the community for several years, that you can do, at least in California and some other states, where could that be an actual hospice unit? And so you use that parole option or that release option, but you go into a hospice. And so just thinking creatively about those different types of opportunities, the Connecticut model, obviously, with the nursing home that Lisa Berry has been involved in, and some others of you have been involved in. And that is a great thought piece and a perspective piece on really imagining a way out of this problem that's not just, you know, not just a family member taking care of a patient, when sometimes that is just not available, although obviously you know, an ideal scenario. And so really thinking a lot about the way that academia can play a role in, you know, partnering with UME and Prison Hospice and other, Michelle and other people inside or in the community, to get this out to a broader audience in the literature as well.
So the Connecticut model people, Jessica DeRing and David, it's a very hard last name, but they're incredibly open to talking about their program. And I think if anybody wanted to do a perspective piece, they'd probably be really open to the publicity. And their model is, I mean, it's truly spectacular. They are mission driven. They care about the population. They learn about people's commitment offense and their behaviors, not so they can say no, but so they can better support them once they get to their facility. It's really a lovely model. So
maybe that's the next community speaker we can have, Michelle, if you'll work with me to invite them to present.
Yeah, sure. They're great.
Right.
We have about 5 more minutes. If there are other questions or ideas, anybody that we haven't heard from yet?
Thank you all for being here. I put my email in the chat. If anyone has ideas or additional questions, or, you know, ways that you think we could be thinking about this differently, please do let me know. Bree, I just want to say about the transitional community model. You know, we really, the challenge is finding a place that a transitional living community that has that ethos and caring environment. And Fernando did find one down in Southern California, and they're very interested in having a bed and kind of piloting something there, with the hopes that eventually, you know, the big dream would be that we have a whole hospice house devoted to this population, or, you know, as Dr. D. Thomas said, you know, something more like.
Strongly recommend talking to Doug Bond.
Okay. Yeah.
I have, and I visited his facilities as well.
Yeah.
I've traveled to South Central Los Angeles so many times in this last year, and I found one place that, in respect to, like Lisa just mentioned, can facilitate this program that I just mentioned. And the reason why I mentioned that is the way it was created, the cultural norms that are involved in the Francisco homes, the amount of homes that they have, and the level of investment from the community that they'd be willing to offer themselves to not only receive training, to set not only one, but maybe 2 beds aside and per home, but I was only asking for 1. And how without any sort of prompting, how they shared with me one of the biggest problems, or one of the most tragic problems that they have is when they receive inquiries from terminally ill patients in the carceral setting for a destination to go, and they have to turn them down because they don't have the medical means to take care of those patients, and how willing they were to receive training just so they can say yes to these patients when they make the inquiry. So like if there was any sort of like research opportunities there to promote to this audience, I would just ask people to think about the level of community investment into research into like the willingness to like some of these transitional homes that are willing to invest in like receiving compassionate release patients into their transitional homes and receive training, and how we can like effectively utilize organizations like CalAIM in California to fund a lot of these programs. So that's what I would like promote or ask people to think about in respect to like research, because all of these inquiries that I've been making, not only over the phone, but in person, has been like really inspiring just to listen to how people are willing to get invested in like a program like this. And in the same aspect of like what you mentioned earlier, Jim, about like staff members asking about some of this programming, a lot of the residents in the transitional homes are also thinking a lot about their own mortality after spending decades in prison, because spaces like the transitional home of the Francisco homes, excuse me, that's redundant language, a lot of them, or excuse me, primarily everybody there is a former lifer. So
this is a great way to end. Sorry,
yes,
I didn't mean to interrupt you. No, keep going. No, I thought you were done. I'm sorry.
Yes.
Keep going.
No, I'm done. So that's fine, Bruce. So I'll leave it there. So
okay, I just to say that I just love that, because it turns everything that we've always said and assumed on its head, which is that no one will take people. And maybe that narrative is finally starting to change. And maybe people actually need to be asked also, how can we help you take people? What do you need so that you can say yes, instead of why are you saying no? And so that is like a very inspiring and hopeful place to end this conversation, which I didn't think we'd get to. But I think, is it fair to say, Lisa and Fernando and Michelle, that people are welcome to reach out to you if they're interested in partnership and, even just running ideas by you or connecting with people? We will try to get the folks from Connecticut to come. Lisa and Fernando, we hope that you continue to come to our meetings, and I know you're both on the list now. So, we're really excited to see anybody who will be at ACCJH in Phoenix in a few weeks. Any last minute thoughts, Nick or Shoka or anybody, or Jamila, anybody else?
Just thank you so much, Lisa and Fernando. That was wonderful.
Incredible.
Thank you for having us.
Thanks, everybody, and fingers crossed on the renewal.
Happy weekend.
Bye-bye.
Have a great week,
everyone. Awesome job, Lisa. Great. Thanks, Shoka.
Of course. Bye.